Good morning, everyone. It's my great pleasure to introduce Dr. Fabrice Jollant, who comes all the way from France. Fabrice is at Montpellier. He's equivalent to assistant professor in Montpellier, more specifically a praticien hospitalier. That's how they call them there. Fabrice had his training in his medical training at the Faculté de Médecine of Paris 11. Then he did his residency in psychiatry at Montpellier. Then where he completed a master's and a PhD in functional imaging, specializing particularly on suicidal behavior. Fabrice has had a very productive and promising career in functional imaging of suicidal behavior, and it's with great pleasure that we have him here. Fabrice has been on a 2-day tour trying to see and learn about the Douglas and about Maguiot, and so he's going to be talking to us today about the neuroanatomy of suicidal behavior. Welcome, Fabrice.
Thank you very much, Gustavo, for the presentation, and thank you very much for inviting me to talk today and for the visit and the meeting, today's meeting. I'm going to talk about suicidal behavior, which is obviously a very complex phenotype, like every phenotype we study in psychiatry. So the idea is to try to understand this complex phenotype by exploring new other levels of understanding, like the social level. It has been done extensively since the 19th century, starting by with Émile Durkheim in France. But you can also explore the molecular and cellular level, and what Gustavo's group is doing with great success. And you can also explore the cognitive and brain level. But as we all know here, when we do this, we actually go from one complexity to another complexity. It doesn't really make things simpler. But if we, unless we try to make links between all these levels of understanding, and that's what I would like to do today with my talk, starting from the clinic and the epidemiology, and going to the neurobiology, and especially the cognitive and functional imaging level. You also have to study the developmental aspects, and if it's possible, the phylogenetic aspects. So, before talking about cognitions and functional imaging, I would like to take some time to try to summarize key findings in previous studies of suicidal behaviors. So the first thing, it looks like people experience, or some people experience, what we call the suicidal process. Suicidal process is a kind of set of emotional and cognitive disturbances that some people experience. It may last 2 seconds in some people. Some people, you know, they learn about news and they jump from the window. Fortunately, it's quite rare, and usually the suicidal process may last some days or some weeks and even some months. And it may also wax and wane. And in some people it leads to a suicidal act. So it's important to understand how this suicidal process works in order to try to take it into account and to treat it and to prevent it. When you talk with patients, you know, I'm a psychiatrist, so I see a lot of patients who have attempted suicide, and when you talk with them, they usually say that they experience this very painful feeling because they have had some difficulties with their job, they have lost their job, or they have lost their wife, and so on. So usually it's problems that are very frequent in life, things you meet every day, or you may have experienced them yourself. So they are very important. It's important to take them into account in your clinical practice, but obviously it's not sufficient to explain the development of the suicidal process. And you need to go further, you need to go beyond these obvious reasons. And when you do this, usually what the patients also report is that they have felt rejected, or they have felt that there was a social disapproval, or they have lost their social status. So what is important is the way they have felt these life events. Another thing you very often found is that these people express a high psychological pain. And Schneidman, who has recently died, and was a very important suicidologist, say that and wrote that the psychological pain is probably at the heart of the suicidal process. There is no suicide without psychological pain. Even in cases of physical disease, people may suffer from high physical pain, but when they consider suicide when they experience psychological pain, not physical pain. So it's important to understand how it works. Who are these patients who feel rejected, who feel this social disapproval, and so on? So, key findings for the suicidal process. Often, but not always, we found external social factors who trigger the suicidal process. Maybe there is this psychological pain, always at the heart of the suicidal process. Another question is what about the axis 1 disorders? Many people suffer from depression when they commit a suicidal act. But what has been found is that depression is predictive of suicidal ideas, but not of suicidal acts. And this is important. But other axis 1 disorders, like substance abuse or conduct disorders, are more predictive of suicidal acts than suicidal ideas. For instance, in people who are depressed, 50% express suicidal ideas, and 30% of people with suicidal ideas will commit a suicidal act. So the idea is that when facing social stress, some people may not experience much. They feel sad, they feel angry, and that's it. Life goes on. But other people may experience psychological pain. And in people who experience psychological pain, some people may recover quite early, and some people may develop suicidal ideas. And some people with suicidal ideas may recover, but others will commit a suicidal act. So it looks like there are 3 steps. Oh, you don't see anything. So the first step is the triggering. A second step is this intense emotional state with psychological pain and suicidal ideas. And the final step is the act. And it looks like, from clinical and epidemiological studies I was talking about, that there are 3 different steps. They are linked, but you may experience the first step and not the second step. And you may experience the first and the second step and not go to the third step. So it's the first thing. The second thing is this question of the vulnerability to suicidal acts. What we know from clinical studies is that a history of suicide attempt is the strongest clinical predictive factor, the strongest predictive clinical factor we know of future suicide. There is a wonderful study by a Finnish group, and they followed 100 people who had attempted suicide, that made a very low lethality suicide attempt, and 37 years later, a quarter of the men had died by suicide, so it's a lot. The second thing we know about suicidal behavior, it says it is associated with some personality traits. like hopelessness, tendency to neuroticism or impulsive aggression. Other things we know about this, in favor of this concept of vulnerability to suicidal acts, is that suicidal behavior are heritable. So we are lucky in the field of suicidology to have wonderful epidemiological genetic studies, family studies, twin studies, and even adoption studies, which clearly show that the suicidal behavior are heritable. And it looks like the transmission of suicidal behavior is co-transmitted with personality traits, not axis 1 disorders. And finally, there are two very important biological reasons. First is this findings 30 years ago by Marius Berg in Karolinska Institute in Sweden, who showed that there are people who have attempted suicide have the decreased 5-HTAA levels in the CSF. So 5-HTAA is the main metabolite of serotonin. And importantly, this decrease is predictive of future suicide. And the second biological study, another important thing about this is that this abnormality, this decreased 5-HT levels, are found whatever the axis 1 disorder. In depression, it's found in personality disorders, it's found in substance and alcohol abuse. So it's a trait, it looks like a trait, which is transnosographic. The second important result in the neurobiological field is this finding of non-suppression of cortical release by dexamethasone, which is also very predictive of future suicide. So it looks like those people are in difficulty to control and regulate their emotions, and especially the stress system. Then there are postmortem studies, and a lot of postmortem studies are conducted here. But I want to show one of your results, Gustavo. I wanted to show this picture by John Mann's group, published in the archives, and showing, I don't know if you see very well, but the idea is that there are abnormalities of serotonergic markers, like a decreased binding of a serotonin transporter in some region of the prefrontal cortex, especially the most medial and ventral regions of the prefrontal cortex. And I will come back to these regions in a minute with functional imaging. We have now two structural neuroimaging studies available, one by Moncul and colleagues in depressed women, and they found a reduced size of the orbitofrontal cortex in depressed women with a history of suicidal behavior in comparison to healthy women. And they also found an increased size of the amygdala in depressed women with versus depressed women without a history of suicidal behavior. And interestingly, the second study found also a reduced volume of the left orbitofrontal cortex in men with schizophrenia with versus without a history of suicidal behavior. So you almost find the same result in men and women, depressed men and depressed women and schizophrenic men, which is this reduced size of the orbitofrontal cortex and probably also the increased size of the amygdala. So these are two regions that seems very interesting in the study of the vulnerability to suicidal behavior. And finally, we have pharmacological data. The first neuroimaging study was conducted by Van Heringen's group in Gand, in Belgium, and they found a reduction of the binding of the 5-HT2A receptor in depressed suicide attempters versus healthy controls. The problem with this study is that we don't know if this these alterations are linked to depression or to the vulnerability to suicidal behavior. So methodologically, when you study suicide or suicidal behavior, you always need a patient control group. So you need a healthy control group and a patient control group. So that's a problem with this study and the next one. Interestingly, Cannon and colleagues, they studied depressed bipolar patients, and in a secondary analysis, they found a high binding of the serotonin transporter in anterior cingulate gyrus in patients with versus patients without a history of suicide attempt. So another brain regions that seems important, apart from the amygdala and the orbitofrontal cortex, seems the anterior cingulate from this region. And finally, there is a study by Layton and colleagues conducted here at McGill, and they found a reduced alpha-methyl-tryptophan, which appeared to be a marker of serotonin synthesis in ventromedial and ventrolateral prefrontal cortex in high lethality suicide attempters. So we have some data from postmortem studies, we have some data from structural neuroimaging and pharmacological neuroimaging showing the interest of studying some particular brain regions in the vulnerability to suicidal behavior. So what I would like to show you now is a kind of framework for future studies of functional imaging based on what we have done in cognitive studies and in functional imaging studies. So I'm not saying that it's a definitive model or everything is clear, but what we know, what I've just presented and what I'm going to present now, maybe we could have the beginning of the model that could be helpful as a framework for future studies. So if we come back to this model, the triggering, the emotional turmoil and the act, the hypothesis is that the development of the suicidal process may be underlined by several dysfunctional cognitive processes, some of them having trait-like characteristics. So that's what we want to test. Which are these dysfunctional cognitive processes and what are their neuroanatomical substratum. So let's start with step 1, the triggering of the suicidal process. There were some small cognitive studies using a modified Stroop task. You know, the Stroop task, for those who are not familiar with this kind of task, you have to read words and you calculate the time it takes to read these words. And in this modified Stroop task, the participants had to read neutral words or negative words or words related to death and suicide. And when you do this, you see that healthy controls in blue read at the same pace. There is no difference, but it's different for the suicide attempters, and especially for the suicide-related words. So it's like there is a kind of what is called the Stroop interference regarding these particular words, and it is supposed to be related to a higher sensitivity or attention to these words here. So this was our first functional imaging studies. We wanted to test the sensitivity to the environment. So we recruited 3 groups of male participants, 13 suicide attempters, so people with a history of major depressive disorder and a history of suicide attempt, 14 affective controls, where people with a personal history of major depressive disorder but no history of suicide attempt, and 16 healthy controls. The participants were not depressed at the time of scanning. That's important. We want to measure the vulnerability, so we want to get rid of the depressive state. And we were lucky to find a lot of people with no medications. So only 2 affective controls and 4 suicide attempters had medication at the time of scanning, mainly antidepressants. There was no significant demographic and clinical difference between both patient groups, which are the most interesting groups, because the difference between them is the vulnerability to suicidal behavior we want to measure. So no difference in age, level of education, NARD score, which is a raw measure of verbal IQ. No difference in depression, in anxiety, in the number of past major depressive episodes, or the age at onset. So very interesting groups to compare. And we show them emotional phases, which was one run of angry and neutral phases, like here, and one run of happy and neutral phases. And what we ask them is to tell us what is the gender of the face you see. So they say, okay, it's a male, it's a female, they have buttons to press, which means that the emotions are processed in the background. We don't ask them to look at the emotion or to recognize the emotion, just to look at the faces. And when you do this, that's what you get. We found an increased activation of the right lateral orbitofrontal cortex in angry versus neutral faces in suicide attempters in comparison to affective controls. So, you know, we do the comparison between angry and neutral faces. So what we get is the emotion. It's not the processing of face by itself. And when you compare people with a history, patients with a history of suicide attempt in comparison to patients without a history of suicide attempts, you've got a high response to the angry faces, but not to the happy faces. You don't get the same result. And the question is, what does it mean? Why do they react to angry faces? So one hypothesis we have to test is that anger expresses reject. No, I was talking about at the beginning of my talk. It expresses disapproval. When you see angry faces looking at you, it means that something is going wrong with you, okay, or with your behavior. So these people may be particularly sensitive to this kind of stimuli, social stimuli in their environment. Another interesting result was to look at what's happening in this particular brain region. So you have healthy controls, HC, affective controls, and suicide attempters. So you see that healthy controls have almost no reaction, but the affective controls are the kind of deactivation of these brain regions, and the suicide attempters have the higher activations. I'm showing you these results because, in my opinion, it's very in favor of the idea that the suicide attempters are very different from the non-suicide attempters patients. They react completely different. It's not just a question of they react much more in comparison to affective control. They just react differently. You know, this group activate these brain regions in response to angry faces, whereas the people who recovered from depression but who never attempt suicide, they tend to deactivate these regions, just like they had a kind of control over this activation. So in our opinion, it's very in favor of this kind of specificity of suicidal behavior. I conducted this study in England, for instance, and they don't believe in that at all. For them, suicide is just a question of depression. Okay, but with all the reasons we've got, those ones and the other ones, and postmortem studies, we really need to study suicide as a particular, specific entity, pathological entity. So first result. Second result, we studied decision making. And you will understand in a minute why I think that decision making has to be studied in this first step of the suicidal process. So decision making can be measured by the very famous Iowa gambling task developed by Antoine Béchara. And I learned that Antoine Béchara joined the McGill recently. So it's very, very widely used task and very clever task. So you have, for those who are unfamiliar with this task, you have 4 decks of cards, A, B, C, D, and you ask the patient to try to win as much money as possible by picking up cards. And when you pick up a card, You may win money, or you may win and lose money. Okay? What the participant does not know is that it will last 100 cards, and it does not know that there are 2 advantageous and 2 disadvantageous decks. The disadvantageous decks are the decks where you win a lot of money, so it's very attractive. But when you lose even more money, so it's long-term disadvantageous. And the advantageous decks are the decks where you win little money, so it's quite boring. But when you lose money, you lose less money, so it's long-term advantageous. And it's made in a way that it creates a feeling of uncertainty. You really don't know what's going on. And the idea of Béchamp is that you have to choose with your feelings. You know, it's the somatic marker hypothesis. So we use this task in 4 groups of participants. healthy controls in blue, affective controls in green, and 2 groups of suicide attempters. One group who had made non-violent suicide attempt, and people who have made violent suicide attempt. And the patients, the 3 patient groups, were not depressed at the time of scanning. What you can see on the graph on the left is that the 2 control groups are not different from each other, and the 2 suicide attempters group are not different either. But the suicide attempters are much more impaired than the both control groups. They tend to go to the disadvantageous decks much more often. And if you look at the graph on the right, you see how they play during the game. And you can see that there is a first part from the first choice until the middle of the task, the 50th choice, where all groups are very similar. They don't know the game, they have to make their own experience, they have to learn. And then there are those who have learned and those who have not learned. And the healthy controls and affective controls, you know, they tend to go to the advantageous decks. They have learned to avoid the disadvantageous decks. And it's not the case for the suicide attempters. And the 2 suicide attempter groups are rather different. The non-violent attempters, they tend to go from one deck to another. They tend to go from advantageous to disadvantageous decks. They don't make a bad choice, but they don't make a good choice either. Which is different from the violent suicide attempters, and you know they are much closer to the suicide completers. And those persons, after the first part of the task, where they try to understand things, they decide to go to the bad decks. They decide to make a choice which is disadvantageous. And this way of playing the game is very similar to the way people with orbitofrontal cortex lesion play in Béchamp's studies, for instance. So since then there has been some replications in adolescence in people with bipolar I disorder, and this year I saw at the EPA Congress 2 posters in affective disorder and personality disorder with very similar results. A second thing with decision making is that it looks very independent of major axis 1 disorders. We recruited more than 300 people, and we found that 2 disorders are associated with disadvantageous decision making, which were a history of suicide attempt and bipolar disorder. And there is something close between both disorders. And the second thing is that decision-making impairment seems correlated with the affective lability traits. So if you have a tendency to have very not to be able to regulate your emotions, to react a lot to what's happening, to feel a high lability, you are likely to have more decision-making impairment. 2 more results with decision making before speaking about functional imaging. We found that decision making impairment was correlated with the number of interpersonal relationship problems. We asked psychologists to have an interview with our patients, and with a checklist, they talked about everything that happened to them during the last year. And then we measured decision making, and we found that there was a correlation. So it looks like it's a correlation. You cannot. It's not a causal relationship, sure. But the hypothesis is that when you have decision making, you may have more problems in life, especially in the context of interpersonal relationships, which are very well known triggers of suicidal process. So if we think that decision-making impairment is part of the vulnerability, it may also influence the occurrence of stressful life events which are likely to trigger a suicidal process in these fragile patients. So it's very circular relationships between stress and vulnerability. The second thing is that we found that some genetic polymorphisms which have been previously associated with suicidal behavior are also associated with decision-making impairment. So the learning process seems to be modulated by these serotonergic polymorphisms. So it looks like decision-making is kind of endophenotype. We have to check this. We'll talk about this in a minute. Or at the end of the talk. So genes influence decision making, which influence the occurrence of life problems. The question was, where does this decision making impairment in suicidal attempts comes from at the neuroanatomical level? So we developed a modification of the original Iowa gambling test. I have no time to go into details, and we used it in the same three groups I've talked about. The first thing, we replicated our results of impairment in decision making in suicidal attempters. The second thing is we did not find any difference in the way the patient experienced a gain or loss of money, the outcome. Okay, what we found, it's a picture very similar to the other ones, but it's not. It's a different analysis. And what we found is decreased activation of the left lateral orbitofrontal cortex for risky versus safe choices in, again, suicidal attempters versus affective controls. So what we compare this time is what's happening in their brain when they choose a risky deck versus when they choose safe deck. And what we found in healthy controls is that the higher the contrast, the better the performance. It looks like to have good decision making, you need to activate your orbitofrontal cortex a lot for risky in comparison to safe decks. If you learn to do this, finally you make good decisions. Okay? And what we found here is that suicidal attempters do not activate the orbitofrontal cortex in response to risky decks. They don't learn to do this, and they don't learn to do this, so they have a bad performance. And in my view, it's very close to the somatic marker hypothesis in a way. They don't know to learn to give this value of risk to some decks, to learn to do this. So they don't know to do it, so their choices are more erratic. They are not guided by this internal feeling that would say, oh, stop, don't go there, you have already been there, and it's very dangerous, so go away. Okay? It does not need to be conscious according to the somatic marker hypothesis. So what does it mean? In the first study, we have a strong activation of this region in response to angry faces. Here we have a too low activation of the same region to risk. Same patients, same contrast. So we looked at the role of this lateral orbitofrontal cortex, and we found that it is related to the encoding of the abstract value of outcomes. So it's not just the encoding of the outcomes. What does it mean? What is the abstract value you give to one outcome? and it's implicated the association between outcome and value. Interestingly, the same brain region is also activated by some social situations like social exclusion. I will show you in a minute a test of social exclusion. It also activates the same brain regions. The same region is also activated by the feeling of embarrassment or regret versus disappointment. You know, the difference between regret and disappointment is that in regret there is self-blame. You're disappointed by, you know, the Canadians have lost. Well, that's life, okay. But you regret to have done something, okay. It's different. And when you do this contrast, the lateral orbitofrontal cortex is lighted. So our idea, it's an hypothesis, is that those people have the kind of inability to give an adequate value to external stimuli. They either give too much value to some stimuli, especially social stimuli, and they give too few value to abstract outcomes and choices and long-term choices. And so maybe their life lack this ability to give adequate value to guide their choices. We have to test this, it's just an hypothesis. Let's go to step 2. So step 2 is the step of psychological pain, suicidal ideas and intent. So we conducted a study in our department with depressed patients. So people who were depressed but who had not attempted suicidal act, and people with a past suicidal act or who had recently committed suicidal act. And we measured with a scale, very simple scale, the psychological pain from 0 to 10. And what we found is that those persons are depressed, and the BDI score were similar across the groups, but when they are depressed, they have the higher feeling of psychological pain. So it looks like suicide attempters, in comparison to depressed patients with no history of suicide attempt, have this higher feeling of psychological pain, whether they have recently committed suicide or the suicidal act was committed a long time ago. And psychological pain was associated with suicidal ideas. So the idea is that this step, you know, the step psychological pain and suicidal ideas are the same step. When you have suicidal ideas, people very quickly have suicidal ideas. It may be very human. But suicidal ideas does not mean suicidal act. It's another step. The idea is that when you I'm going to say a word about this funny task. It's a paper published in Science in 2003 in healthy controls, and they used this social exclusion task. So you see there are two people playing with a ball, and there are your hands here. Okay, so it's your hands, and the idea is you are asked to play with a ball, and you are instructed that there are other people outside the scanner playing with you. So these are real people actually. So you play the ball with them, so you can choose to cast the ball on the right or on the left, and so you play. You just play. And then there comes a time when the other guys, they don't send you the ball at all anymore. But nobody's said about this. You know, you suddenly realize that you're excluded from the game. And when you do this, when you compare the exclusion part and the inclusion part, you see that you activate the anterior cingulate I talked about earlier, and also the orbitofrontal cortex. So what psychological pain has been very rarely studied actually in with functional imaging. There are very indirect assessment of psychological pain, which is a shame because it's very, very important in psychiatry. So we plan to study psychological pain in relation to the vulnerability to suicidal behavior, following what I've said the slide before about this higher feeling of psychological pain in suicide attempters. And finally, there is a study by Oquendo. It's a PET studies, and they compared high versus low lethality suicide attempters at rest and after fenfluramine injection. And when you do this fenfluramine, you activate the serotonergic system. And they found that two brain regions which are quite medial, in the medial prefrontal cortex, are activated in high versus low lethality suicide attempters. But what they found, and you can see that on the graph on the right, is that this region is correlated with suicidal intent. So it looks like this medial region is encoding the suicidal intent. So to finish with this step 2, the idea is that the medial prefrontal cortex, including the cingulate gyrus, may be very important in this step. It is also implicated in ruminations, and you know that ruminations is very high in suicide attempters when they are depressed. It's also implicated in self-reference, and here we have a very interesting field of research. How is self and the perception of others encoded in the brain of suicide attempters? We have no ideas, but from other studies we know that self-reference is also encoded by the medial prefrontal cortex. It also encodes guilt, embarrassment, shame, the initiation of action, and also verbal fluency. So this region may be important in confronting informations on values of external stimuli that comes from the amygdala and the lateral orbitofrontal cortex, and information from the representation of self. So it's the confrontation of both that may lead to suicidal act. And finally, step 3 is a suicidal act, and I have not much to say about this, unfortunately, and although it may be the most important step. Who are these people who will commit a suicidal act when they have suicidal ideas? We don't know, because there has not been one study comparing suicidal ideators to suicidal attempters. Maybe the dorsolateral prefrontal cortex may be implicated. That's an hypothesis, because it's implicated in response inhibition, in cognitive control, and in taking into account contextual and past events to guide actions. But we really have no idea about this. This has to be tested now. So in summary, I would like to propose you the neuro and cognitive model of the vulnerability to suicidal behavior, starting with the ventrolateral prefrontal cortex and the amygdala, which may underlie a deficient value attribution, which would be responsible of the sensitivity to the environment, decision-making impairment, and also anger, the automatic triggering of anger and anxiety, which are very important emotions in the suicidal process. The next step is the cingulate gyrus and mediodorsal prefrontal cortex, which are implicated in the regulation of the emotional response, and this would be altered in suicide attempters, leading to psychological pain, ruminative thinking, suicidal ideas, and suicidal intent. And in some people it's not sufficient, and it will go to the suicidal act, maybe through the interaction with the medial and dorsolateral prefrontal cortex, which may, in some people, facilitate a behavioral response, in this case, a suicidal act. Okay, it's just a framework again. A lot of questions remaining, and so a lot of work to be done. So that's good for us. It's less good for the patients, but we have a lot of things to do. Are there other brain regions which are implicated? What are the connections between these regions? How are they? Do they work also? Are there other cognitive processes that may be interesting to study and know their neuroanatomical substratum, and can we modelize all of this? That would be great. I think we also have to investigate at this level gender difference. Obviously, at the clinical level, there are difference in rates of suicide and suicide attempt according to gender. We have to investigate the effect of age. I think that there are differences between adolescents, adults, and old adults. We have very preliminary results showing that decision making is not impaired in old age people who have attempted suicide, unless they have attempted suicide at an early age. So people who attempt suicide at very late age for the first time may be very different cognitively and neuroanatomically. It has to be studied. What is the effect of early traumatic events on all this process I've described? What is the genetic modulation of this brain functioning? We're about to finish a study in Montreal which will investigate this. We need to do PET studies and try to link the neuroanatomical level and the molecular level. And also, and it's the topic of a project we have here with Gustavo, are some of these cognitive impairments have shown endophenotypes, and are there protective factors? And to do this, we have to study relatives of suicide completers, and it's obviously it's possible here because it's well organized, and so you have access to this population. It would be great. It has never been done. It would be great to use this cognitive battery and to ask these patients to assess these patients with this battery. And finally, it's the final goal of all we are doing. It's not just to know the physiopathology, but will this be useful to prevent suicide? It may be very useful for almost half of them who have already attempted suicide. Unfortunately, some of them die at the first act, but at least I think we can have some secondary prevention. And these results, cognitive and neuroanatomical level, may help to create new psychotherapy, or to guide medications, or to guide sociotherapy, or to guide transmagnetic stimulations, and so on. So my goal is to define things that could be useful for clinicians and therapists. And I would like to finish by thanking all these people in Montpellier, in Geneva, where we conduct the genetic studies, in Créteil, close to Paris, and all the collaborations we have with London, Pittsburgh, and Cardiff, and now the Douglas Institute. Thank you very much for your attention.
We have time for questions. We have
I just wonder if you might say something about how alcohol just facilitates all this.
Yeah, I don't know. I checked this. The effect of acute alcohol intake on the brain. There are some few studies, and I wished I could find something very simple, like it deactivates this brain region, so it's easy. But actually, it works everywhere in the brain, so it's very difficult to know how it may help to facilitate the act. That was my idea for step 3. If we know how it works, it's obviously a very important trigger of act. But I don't have any clear idea now.
So, well, thank you for your presentation. I was very interested by the psychological dimension to the identify, say, decision making as some form of attribution, but do you have also other processes in mind, whether it's kind of a bias or have you thought about other potential cognitive processes that will also contribute to that?
Yes, there is one which has been studied, which is verbal fluency. I have not talked a lot about this because I don't know what to do with this. Verbal fluency has been found to be reduced in suicide attempts, as in many studies, and this could be related to the medial dorsal prefrontal cortex. But what does it mean to have verbal fluency reduction? But one explanation may be that if you're not able to communicate verbally, you may tend to communicate with your body and with actions, yeah, even if it's self-destructive. It's a psychological explanation. I don't know the value of this explanation, but obviously there is something. We in our last neuropsychological studies were recently submitted for publication. Again, we found this verbal fluency reduction in suicide attempts. So this is one cognitive process that has been well studied. I think we need more neuropsychological studies. And so neuroimaging is wonderful, but we really need to try to link the cognitive processes and the neuroanatomy. And what I was interested in studying functional imaging because it also helps to discover new cognitive alterations. It's not just the neuroanatomy. So just like decision making, it's a very complex process, obviously. And we were interested in doing functional imaging of this complex process because it's very naturalistic. It means something. When I first started this study for my MSc year, many patients told me, "Oh, it's just like in my life." So it was interesting to use this task because it's just like in their life. But it's very complex at the same time. So when we want to understand the more primary, more simpler cognitive process, we have to go further. But with functional imaging, we found that what's wrong, it's the lateral orbitofrontal cortex, but it's also the processing of risk and not of outcomes. It's not that they are too much sensitive to reward and too less to loss. It's not the problem here. So I think that's an interesting thing in functional imaging. You know that, but the people don't know these aspects of functional imaging, the link between cognition, functional imaging, and back to cognition. Are there other cognitive processes that have been studied? There is something about memory and attention by the group of John Kelp in Columbia University, but I do not agree with their interpretation of findings. Oh, this is Bruce Springsteen. Okay. I think that the attentional and memory deficits are linked to the depressive state and not the vulnerability to suicidal behavior. So we need more studies to confirm this. Yeah, and that's it for the moment.
Yes, so if suicidal behavior is more associated with impulsive traits than depression, I wondered if had you thought to use some sort of control group with impulse disorders or in addition to say, depressive control group, just to see if what you're looking at.
People who act, but not a suicidal act.
Yeah, that if you're imaging impulsive behavior as opposed to suicidal behavior.
Yes, that would be a great idea. Yeah. I had not thought about that. My idea for the next study is first to define what would be interesting at the cognitive level, and also to have 4 groups of patients. So it's a lot for the analysis, which would be healthy controls, affective controls with no suicidal ideas. Half of depressed patients have never suicidal ideas, and people with suicidal ideas and people with suicidal act. So try to dissect the suicidal process. But it'd be interesting to what are those people who also commit suicide. But a little bit embarrassed with the concept of impulsivity. What is impulsivity? Obviously, motor impulsivity, cognitive impulsivity is 2 different things. Cognitive impulsivity is correlated to the activation of the lateral orbitofrontal cortex, but not motor impulsivity. So this inability to delay gratification, which is cognitive impulsivity, is related to this region, but not motor. It's something else. And another thing is that many suicide attempters are not impulsive. They may commit an impulsive act. They have this long suicidal process, they don't feel well, they have psychological pain, suicidal ideas, it comes and it comes back, and it lasts several weeks, and one day they say, okay, that's enough, and they commit a suicidal act. So it looks very impulsive, but it's not really, and they are not impulsive themselves. They have no impulsive personality. I don't know what's your experience with that, but we also meet impulsive patients, like borderline patients, of course. But a lot of people are not impulsive at all. It was shown by Baca Garcia in Madrid. No correlation between the impulsivity of the act and the impulsivity trait.
My question was regarding what would your insight be in regards to the similarities as well as differences between the neuroanatomy of suicidal behavior as well as neuroanatomy of antisocial behavior, more along the lines of criminal-like, like murdering behavior?
Yeah, there are obviously a lot of similar regions which are involved, starting from the amygdala. James Blair, who is the great specialist of the antisocial personality, says that the first problem with this disorder is the amygdala. But there are also data with the orbitofrontal cortex, and that will be a great field of exploration. What makes someone commit a suicidal act or external act, aggressive act? What makes the clinically, there are people who kill their family and then they commit a suicidal act. So are they different? Is it the influence of the environment at this moment? Maybe in people who are in prison, it's a case. These are people who may be aggressive when they are outside, but when they are in prison they commit suicidal act because they have no choice. So the same basic dysfunctions, and it's very close, yeah. But to my knowledge, there is no clear studies investigating or comparing both. Something we should do.
Would you, in your work, distinguish between suicidal behavior versus suicidal behavior? Is it a different pattern, or is it just that people who commit sort of parasuicidal acts go through the process differently, or?
It's very, very important question. Usually we only keep people with the high intent. Lethality is something different. It is not completely... It is correlated with the intent, but not completely. Some people may... we know that in our clinical practice, some people may have the high intent and they take some medication because they think that it's lethal, but it's not. And some people may take very high risk and die, although the intent may be not so clear. There is always a part of ambivalence. That's why I think there are probably several dysfunctions, because it's not natural to kill oneself. It's against the evolution. Okay, it's against what allowed us to be here. So you need many things to go to the end, and many things means that you're very. A lot of people are very ambivalent about their art until the end. Until the end, we know of people who have hanged themselves, and at the last minute they have tried to, take out the rope, and you see that the skin of the neck is pulled out, or things like that. So it's. But the thing is, with our studies, we exclude acts which are not where there is no clear intent to die, especially scarifications, which in borderline patients you see that they explain that they felt very anxious, and so they had to do scarifications, and then they felt better, but they did not want to die. And at other times they committed suicidal acts, and they can say, okay, this was a suicidal act, but this was not. So it's linked somewhere, but it's something different. So this is another thing that should be studied. What is the difference? Maybe scarification is just the first step. You feel, the anger, the stress, and you have to reduce this.
Okay, we have to stop. I'd like to thank you very much for this.